to give an update on post-abortion contraception. I'm honoured, particularly since so many experts in the room on this subject. In this update, I want simply to focus on immediate post-abortal contraception, and actually more specifically on the most effective methods, that is the long-acting reversible methods. To set the scene, why is immediate post-abortal contraception so important? Well, it's so important because we know that most women ovulate that same month, and about half of women will have resumed sexual intercourse by about 2 weeks. And actually, Ingrid Sav and Christina Gemsel-Danielsen showed in a study of women having early medical abortion that 16%, which I think is about 1 in 6, had actually had intercourse by 1 week after mifepristone, a time when they're still bleeding. So I think that, clearly we have underestimated the need in the past for immediate contraception for women having abortion. At this time, women may be highly motivated to start an effective method, and of course for them it avoids an extra visit to a healthcare setting. And we know that even when we make appointments for women to come back for follow-up, that many of them don't attend. And indeed, many studies have reported failure to attend rates of in the region of 50%. The World Health Organization, in their policy document, Technical and Policy Guidance for Health Systems in 2012, recommends that all methods could be started at the time of a surgical or medical abortion. And we know that in many countries we have high rates of women who have had an abortion who go on to have another one. In Scotland, our repeat abortion rates are in the region of 30%, and in the USA, it's in the region of 50%. And we know that not only do the most effective LARC methods, that is the IUD, the IUS, and the implant, prevent unintended pregnancy, but there's also global evidence that immediate initiation of the IUD and the IUS at the time of an abortion can prevent repeat abortion. And we have also shown in Scotland that immediate commencement of an implant at the time of medical or surgical abortion can also prevent repeat abortion. What do we need to think about when we're considering immediate initiation of an IUD or an IUS at the time of abortion? Well, there are numerous advantages. For the woman, the health provider is already present, and of course it's convenient for her, avoids an extra visit. It also avoids another examination and additional discomfort, and it might be easier because the cervix will be dilated. What are the potential concerns? Well, the potential concerns are, might expulsion be higher since the cervix is dilated? Would there be a higher risk of a complication since the myometrium is soft? And what about infection? Might there be a higher risk of infection if there's retained products? Well, I think one of the best studies to date that has looked at immediate insertion of an IUD or an IUS at surgical abortion is that from the USA, from Bednarek and colleagues in the New England Journal of Medicine in 2011. And in this study, it was a randomised controlled trial. They randomised over 500 women to either immediate insertion of the device of their choice or delayed insertion, that is 2 to 6 weeks later. And these were women who were less than 12 weeks pregnant, who'd either had a spontaneous abortion, that is a miscarriage, or were having a surgical termination. And they found, surprise, surprise, that insertion rates were higher in women who were randomised to immediate insertion, but you can see that about a third of women didn't come back, even a few weeks later, to have a device if they were in the arm where they were randomised to delayed insertion. And you can also see that there was a very low complication rate, there were no perforations, a low risk of infection. And actually in this study, the expulsion rates were similar, 5% in the immediate group and 3% in the delayed group, and that was in the first 6 months. And again, very importantly, you can see that for women who were randomised to immediate insertion, that there were no unintended pregnancies, whereas 5 did occur in the delayed group, because of course women didn't always come back to have the device inserted. And these findings were very similar to what's been reported in earlier systematic reviews and in an earlier Cochrane review, which showed low risk of complication and that insertion this time is safe. And the most recent Cochrane review from 2010 also reported that there may be a slightly higher expulsion rate with women who have an immediate insertion after a second trimester abortion compared to after a first trimester abortion. Well, what about medical abortion and an IUD and an IUS? Well, good old WHO have also given us some advice that following medical abortion it can be inserted as soon as it's reasonably certain that the woman's no longer pregnant. And so for all intents and purposes, this is when expulsion has occurred. But even for women who are expelling the pregnancy in a hospital or on a clinic, it can be quite difficult to organise. It can be quite difficult to have a healthcare provider who's available at the time the woman expels the pregnancy to then insert it. And of course, as we've heard from Christian, increasing numbers of women around the world are opting for home abortion and choosing to go home to expel the pregnancy. So some services, like our service in Scotland, have tried to get around this by trying to arrange for women to have what we call a fast-track referral system, so that they're given an appointment to come to a specialist contraceptive service within the next few weeks to have the device inserted. But, of course, surprise, surprise, what we see is that about only half of women actually attend for insertion. So, again, Ingrid Sav and Christina Gemsel-Danielsson from Sweden have looked at this and conducted a really nice study published this year in PLOS ONE. It's a randomised controlled trial of 129 women having first trimester medical abortion, and they were choosing either to have an IUD or an IUS, and they were randomised to either early insertion of the device, so 5 to 9 days after mifepristone, or delayed insertion coming back to the clinic at a 2 to 3 week interval. And you can see that, again, surprise, surprise, a higher insertion rate in women who were given an appointment to come back sooner. And in fact, the failure to attend rate, or did not attend rate, DNA rate, was 1.5% for women who were in the early arm, but was 11.5% for women who were in the later arm. And the study showed that insertion at this time was safe. There were no perforations in this cohort. The infection rate was low. There was only one infection, and that was in a woman in the delayed group. Expulsion rates were similar, and interestingly, they found that expulsion was not associated with the measurement of endometrial thickness and ultrasound. And timing of insertion did not affect bleeding, but this study again confirmed what we know already, that women who choose a Mirena after an abortion can benefit from the beneficial effect that the Mirena is known to have on bleeding, and women having a Mirena had fewer days of bleeding than women having an IUD. What about the other benefits? Well, what about the cost benefits? Well, Salcido and colleagues have recently published the findings of this cost analysis in contraception, and this is looking at a cost analysis of immediate insertion of an IUD compared to delayed insertion. And this is based on a cost analysis from the USA, and they calculated that for 1,000 women who would be having immediate insertion of an IUD at the time of abortion rather than delayed insertion, over a period of 5 years, there'd be 400 fewer pregnancies, 180 fewer births, and 160 abortions would be averted. And they calculated considerable cost savings in the region of thousands of dollars at 5 years, and that the cost savings persisted even if the cost of the IUD were much, much higher, even if it was in excess of $1,000, and even, it was still a cost saving, even if expulsion at this time was much higher than what's reported in the literature. It was even a cost saving if the expulsion of an IUD at this time was up to 30%. Well, what about inserting an implant at the time for termination? WHO, in that same policy guidance, have recommended that it can be inserted at the time of surgical abortion or at the time for medical abortion, the first pill or the second pill. The first pill usually being mifepristone. Now, we have looked in our service in Scotland at women having a method of contraception at the time of an abortion. Scotland, like the rest of the UK, offers free abortion and free contraception to all women, and in our service we've offered all methods of contraception to women at the time of medical or surgical abortion, including the implant. So we did a case note review of approximately 1,000 women who were having a medical or a surgical abortion in 2008, and we looked to see the method of contraception that they were actually given at the time of the procedure, and whether they came back to the same service within the next 2 years for another termination of pregnancy. And we found that women who chose to have an implant inserted at the time of a surgical or medical abortion, that compared to women who left with a combined contraceptive pill, women who had an implant were 16 times less likely to come back in the next 2 years for another termination of pregnancy. And in this study, the protection that was afforded in terms of their reduced risk of a repeat abortion was comparable to what we observed with the IUD and the IUS. And actually in this same study, women who left with a combined pill, or indeed the injectable Depo-Provera, they had the same risk of coming back as women who left with no method. Now this study is important, I think, because the women who are choosing the implant are, and were in the study, predominantly younger. And in this study, women who were under 25 years of age, a third of them chose the implant. So it's really important, particularly for this young group of women. Now, another study that I think has been really important is that of Madden et al. In Obstetrics and Gynecology from 2012, which showed that amongst women having an implant inserted at the time of termination of pregnancy, that the continuation rates in the next year were high. They were in the region of about 80%, and they were no less than women who had the implant inserted 7 weeks later. And for me, I think that's very reassuring, because perhaps some of you, like me, will hear stories from colleagues such as, oh, we should not be putting an implant in at the time of termination of pregnancy. The woman will have it removed several weeks later because she doesn't like bleeding, or it reminds her of a termination, etc., etc. So I think that this evidence is really important to show that insertion at the time does reduce repeat abortion rates, and continuation rates, even when it's inserted at this time, are very high. What about the bleeding pattern with the implant? Well, there's no evidence that inserting an implant at the time for medical termination will affect its efficacy. But of course, I think bleeding is important, because increasingly women are having simplified regimens of follow-up after medical abortion. Now, Christian's already discussed the use of a pregnancy test, and we in our service in Edinburgh and Scotland use the same pregnancy test, but in combination with a series of questions about days of bleeding and symptoms of pregnancy, and whether the next period has arrived, to screen women who might have an ongoing pregnancy after early medical abortion, something that occurs in approximately 1 in 100 women, and arrange for them to come back to the clinic for a confirmatory ultrasound. And you can see on this slide the sort of pictorial information we give to women. We advise them to get in touch if they haven't had at least 3 days of bleeding, if they're still feeling a bit sick, or if their next period doesn't come by a month after treatment. So clearly, I think it will be really important to have good quality studies conducted to know whether inserting the implant at the time of medical termination of pregnancy does affect the bleeding, or does affect the validity of any of these tools that we're currently using to advise women when they need to get in touch with us in case there could be an ongoing pregnancy. So I think it's really quite clear that increased use of the most effective methods of contraception, the IUD and the IUS and the implant, can prevent repeat abortion. But what do we do as providers? How can we increase uptake amongst women? Well, I think there's 3 things that we can do. One is women. We can provide them with good information. We can help dispel the myths and the misconceptions that they may have, and provide them with accurate facts about these effective methods of contraception at the time they attend the service. My colleague Lucy Mickey, who's in the audience, conducted an anonymous self-administered questionnaire survey of over 100 women who were attending our service requesting termination of pregnancy, and she was asking them whether they believed some common negative statements in relation to the IUD and the IUS, such as it can move around your body, it can puncture your ovaries, it can rust inside you, etc. And interestingly, she found that women who believed these negative statements were in a minority. But there was a sizable proportion of women, in excess of a third, who really just didn't know whether to believe them or not. And for us, we have assumed that that reflects just that women lack knowledge about these methods. So clearly, even when women are coming requesting termination of pregnancy, it's important to provide good information about the methods at that time. As providers, we ourselves need to be educated about the timing of insertion, and we need to know that it is safe to insert these LARC methods immediately at the time for an abortion. And of course, we need to be trained to be able to offer them to women. And thirdly, I think it's important that we are funded to be able to provide these to women. There's really good data, of course, from the Choices Project from the USA that's shown that removing the financial barrier to LARC leads to a massive increase in uptake. And there are other studies, such as from New Zealand, that's shown that providing no-cost LARC to women at the time for termination of pregnancy can dramatically increase the proportion of women who will be able to avail themselves of that method. And the study by Rose et al., there's a 6-fold increase in the number of women who were choosing to have a marina immediately at the time of termination of pregnancy when the financial barrier was removed. So in conclusion, I think, therefore, it's quite clear that immediate uptake of the most effective methods of LARC, the IUD, the IUS and the implant, at the time for termination, has advantages for women, and it's more convenient for them at this time. And it's quite clear now, not just with the IUD and the IUS, but also with the implant, that inserting these methods at the time of the abortion significantly reduces a woman's risk of a repeat abortion. With the IUD and the IUS, at the time of surgical abortion, it's safe, it's low complication, and it's quite clear it's cost effective. And with medical abortion, I think it's quite clear that if it can't be done at the time expulsion occurs, then it's quite clear from the Swedish study that the sooner the better. So I think now is the time for those of us here who are working in abortion care, that we should be trained and funded to be able to provide LARC to women at the time of the procedure. Thank you very much.
Thank you very much, Sharon. So important, this topic, and your last line, I really